And it's to be able to make sure we have the recordings and more people can join. That doesn't mean that I'm going to stop meeting with people face to face in person. I'm just going to call those community forum meetings and then have those periodically where people can come and meet with me face to face, because I really did enjoy that piece of it. But we were starting to grow in number and it was getting tough to do this. Excuse me. And a lot of people couldn't get to James Street. So, and I don't know if she's on yet because Rosalie made me promise that we stream these or record them. So I listened to her. Some of you I'm seeing on the side, I don't know you. I'm Dr. Michael Brashears. I am the CEO for CMH of Ottawa County. On July 30th, I'll be back in this role for a full year. It feels days that it's been longer than that, some days much shorter than that, just depending on what's going on. So during this process, I'm going to kind of go through slides and then I'm going to open it up for questions about what I'm presenting. And Amanda, I don't know if there's a way for you to keep track if somebody raises their hand that I can see it, because I am the typical guy. I can't do two things at once. I can't talk about going, oh yeah, somebody's in the chat, and I'm still getting used to this format in Zoom. I'm used to doing things through Teams, which I'm very familiar with. So it's going to take me a couple of times to get good at this. So I will need some help determining if somebody has a question. In fact, if one of you can scroll to the bottom where it pops up, it says raise their hand. If you could do that so I can see, thank you. All right, cool. Oh, Mr. Rockman, thank you. All right, and then there should be it disappears or you can lower it, I believe. All right, cool. So if there's something in the middle of the presentation, you have a dying question, raise your hand and I'll try to see it.
I will also be watching and piping in if somebody has a question. So I'll help out.
Excellent. Okay, so I'm going to do the share screen. And so now if I've done this right, you should see a slide that says Medicaid state funding for community mental health, a call to action. Amanda, is that going through well? Can you see that?
Yep, it's showing.
Okay, great. So I'm going to try to, in the next hour or so, give a general description and some general talking points on what is a very complicated situation in the state of Michigan in terms of our funding, even though it really shouldn't be complicated at all. And so what I want to attempt in this meeting is to kind of go through the issue that I see with the Medicaid state funding for community mental health in terms of the budget, and just why we think it's a problem in terms of CMH system. What this discussion is not about is if we should change the way we fundamentally fund the system. I'm a big advocate of looking at protecting certain population groups with their funding being separated. Right now in the CMH system, besides some specific waiver services, all of the money comes to us in one big pot, so to speak, with a couple of different strands. And so CMHs are asked to provide the full array of services for all the populations we serve, the mentally ill, severe emotionally disturbed children, autism, IDD adults, and the like. And I think just personally, and it's not part of this discussion, just people know who I am, that we have to find a way to protect the DD funding so that it doesn't get depleted enough so that we can't really do what we need to do with that population. It already takes up 40 to 50% of all the expenditures we have. And if we're not careful, it can be difficult. But this isn't about that. What this is about is, okay, let's switch the slide. Okay, so what is the issue? Well, the Michigan State legislators appropriated $4.3 billion to fund the CMH system. That means they put in the budget $4.3 billion to fund the entire CMH system. If you remember, the CMH system is comprised of 46 CMHs serving the 80 plus counties, and then 10 kind of regional entities or PIHPs that manage the Medicaid money right from the state to the CMHs. And so the legislators last year built a budget that said 4.3 billion. And the Michigan Department of Health and Human Services has indicated that they're going to withhold 232 million of that 4.3. So they're only going to push out 4.1 million. So what that's doing with what we know about the CMH system for this fiscal year that we're in, it started on 10/1/24 and it ends on 9/30/25, is we believe it's going to create a $210 million deficit in the system. So to recap, legislator says 4.3 billion. Here's the budget. It goes to the specific department, and I'll tell you what they do in a moment. And they say, well, out of that 4.3, we're going to only push out 4.1, which right off the bat creates a structural deficit within our system statewide. So why does the state think why are they withholding the money? Simply put, the Michigan Department of Health and Human Services believes that we don't need it. That's the simple answer. Legislation says 4.3. They go through their process once it gets to the department that manages it, and they say, we only need 4.1 of it. And that 232 million is still around. It's not gone. It hasn't disappeared. They could send it out. So simply put, they don't think we need it. More complex, they conduct what's called an actuarial analysis. And the way they do it is based on services and cost data in our CMH system over the past 2 years. They then project forward how much they think we're going to need in the system. The problem with that, it's 2 years behind real time. So they're calculating what we need, say, in fiscal year 26 based on data that is for 23 and 24. So they don't even get real-time data, and a lot has changed. So I want to make sure people are grasping what I'm saying. The legislators say, here's your budget, 4.3 billion. The department says, through our process, we're going to simply, I'm sorry, my phone's ringing. We're going to simply push out 4.1 based on what we need, even though the system says we need every dime of it. Do anybody have any questions thus far on what I'm saying? So Amanda, you'll have to check because I can't see the hands.
Yeah, so we have 3 people with their hands raised. I can allow each to talk. So just a moment.
So it looks like it's Tracy and then TW and Steven, right?
Yes.
Tracy, go ahead.
It's like Tracy's still muted.
Yeah.
Okay, I unmuted myself. Can you hear me now?
Yes, perfectly.
Okay, thanks. It's not really a question, it's more of an observation we've had as we've done the actuarials on our end, is that it asks you what you're spending, but not what you should be. So when those were being done 2 years ago, or whatever
Right.
that lag time is, or whenever they're being done, we were so understaffed that what we were doing wasn't necessarily what we should be doing. So we're also not only lagging in that, but it wasn't representing or asking the right questions to grab that. And we provided that feedback, but I wanted to also share that.
That's important, Tracy, because there's supposed to be some type of calculation of what you think you're going to need based on increase of utilization. And it's not, it's not,
They didn't ask the right questions, right?
yeah, so it doesn't really assume a lot of growth, right?
Correct. It
Steve?
doesn't assume growth and it doesn't even assume what you actually should be doing to provide the service.
Right,
Yeah.
perfect. Stephen, you had a question?
You hear me?
Yes.
What's done with the withheld money
Sitting there right now.
and just sitting in a bank account? I mean, what's it doing?
Yeah, I mean, it's a lot more. I'm giving it a very simplistic a simplistic answer because technically the money's there, but there's a whole process that one has to go to reclaim it, right? So it's not sitting in some account collecting interest. It's like the department has to keep asking for the appropriations to be released, and I'm giving you a very simplistic answer. But Stephen, the bottom line is they can send it. They can do a adjustment to the CMH rates that they're sending to all of us. They often do rate adjustments during the year. They're just not indicating that they're going to release the money, even though you'll see in a moment the whole system is screaming that we need it. So I'm trying to give a simple way of understanding it. The money was appropriated. They're not pushing it out. We definitely need it. And I'm going to show why in a moment. Does that help?
Yeah.
All right. TW, you had a question?
Yeah, can you hear me?
I can.
Okay, you said that the state doesn't have real-time data. They're 2 years behind. Yet we
They
know
calculate the rates, yeah.
organizations and businesses with larger budgets than this have real-time data. That's how they operate every month, every quarter. What's
I
wrong
lost
with the
you.
state of Michigan?
Lost your audio.
Sorry, can you hear
And
me?
it says, yeah, it says my internet connection is unstable. This is what I hate about virtual. All right, but I think your point was, why don't we have real-time data? And they can do it. It's a huge undertaking to gather it. The message I want to convey is there is money to send to the system that needs it. And I was just giving like an overview on how that can happen. But make no mistake about it, the system needs the money. And they should release it. I call it almost like impounding it. Now, I'm not trying to make the state sound like they're disingenuous or malicious, but it is interesting that, and you'll see in a couple of slides where the bulk of the system are reporting huge deficits and need the money. And I guess we're okay with just cut everything, which you can't do. So I'll get to that in a moment. Jackie, do you have a quick question? Yeah, I can't hear Jackie, so I don't know if it's on my end or not.
I can't hear either. Jackie, are you unmuted?
She is. Okay, there's something going on with our ability to hear other folks, and it may be the bandwidth of the internet. So we'll have to try that again in a moment. I'm going to proceed on with the presentation. Amanda, can you still see the slider?
Yep, I can see everything still.
Okay, thank you. Sorry, folks, my first time doing this.
Sorry, we have
Okay,
another hand raised.
let's
Do we
move
want to
on.
wait until another question and answer session?
Yeah, we'll just wait. Yeah.
Okay.
So what I'm going to do, so why does the system have a projected, wait, let me back up one moment. Okay. So simply put, they don't think we need it. And specifically, they're using data that's 2 years behind to project out what we need. So of course, the CMH system is saying we do need that money. So why does our system believe we have a projected deficit? So you should see now this kind of PDF that pops up on the screen. It should say drivers of budget shortfalls. And this is sent out by the CMH Board Association that represents all of us. And I can make this available to anybody that wants it. We're going to definitely try to email this whole presentation, the recorded video and this description out to anybody that wants it. But we've been facing this challenge the last several years. It's not a new phenomenon that the state is saying we don't need the amount of money to provide the services that's originally budgeted. But here's some of the variables that go into that. So really there are loss of Medicaid covered lives plus increased demand of service. So when we had the health emergency, the Medicaid benefit was expanded out. And it increased the amount of money each CMH gets for its services because we get a small portion for every single Medicaid person in our county. And there's a box that will show you that in a moment. So when the health emergency was over, people fell off Medicaid because the old requirements came back. And our demand for services increased. So we had less people on Medicaid and our services increased. And there are certain types of services that have increased dramatically, which I'll cover in a moment. But please remember that every CMH in the state has to provide service to anybody with the Medicaid card or not if you meet eligibility. And our budget is only based on 6% of the Medicaid people showing up. So if the demand keeps increasing for services, it's not like we get extra money for the extra people showing up, if that makes sense. We get one big payment a year and 12, broken up in 12 months of all the Medicaid recipients, but it's only enough to cover if 6% of them show up. If more than 6% of the Medicaid population shows up to CMH, we go bankrupt anyways. So the important thing to remember is that it's not a fee-for-service arrangement. We don't get extra money for every service we provide. We have to provide all the services with the money we have, regardless of how many people show up. And that's had a huge impact. You combine that with just inflation. It's gone up considerably, and you can see on the box to the right, Michigan's budget, Michigan's inflation, funding for core mental health and IDD services is less than 10%. It doesn't even keep up with inflation. And if you're a provider, you know this. Your cost or if you're someone that does self-directed services, your cost to deliver that service is multiplied 5 times easy. And the rates that we're giving or the funding available hasn't kept up with inflation. So we've had a loss of covered lives, increased inflation, skyrocketing inpatient psychiatric hospital costs, which the CMH system, each CMH pays all of the psychiatric inpatient costs for everybody on Medicaid and everybody that does not have insurance. Different funding stream, but the same issue. There's been a 30% increase of that. And the rates are up to $1,200. We have some contracts that are more than that. They're $1,400 a day. The state gives us about, in their budget, around $1,000. So in Ottawa County, every single time someone gets hospitalized, we lose $200 because the amount of money the state calculates for inpatient costs and send to the region shorts us $200 every day. So we already know we have a deficit there. And by the way, the state is aware of this. And I know that Mary Dumas, our Lakeshore Regional Entity CEO that manages it, knows this very well, that we're losing money every single day. Sometimes we go in the hospital. So there's a deficit there. The other major factor of why we say we need the money. And again, what I'm doing is justifying why we as a system are saying, send us the money that you've actually put in the legislative budget to do. We need it. And the state says you don't need it. And we go, let us show you why we need it. So all of the information that you are seeing, the Michigan Department of Health and Human Services are quite aware of this. And so this is a compelling case that we're not just saying, send us the money because we need more money and we're mismanaging. We're saying send us the money because real services need to be funded. One of them is the cost of autism. So across the state, demand for but particular service, applied behavior analysis, has steadily increased. The costs have also increased. In fact, in this fiscal year, the one we're in, we had to provide a rate increase. We had to give a rate increase to those providers to $66 an hour. And the state added more money to our budget, but not enough to cover the increase. So we had a deficit there. Now, like I said a little while ago, this isn't just a new phenomenon for this year. Last year, they withheld $137 million. Ottawa County ended up with a $4 million Medicaid deficit last fiscal year because they did that. Fiscal year 2023, they withhold $246 million. And this year, it's projected to be 210. So literally, in the last 3 fiscal years, the citizens of the state of Michigan and the people that need these dire services has had $600 million taken from the system. It's not like we didn't say we need it, and I'm going to get into that more in detail. But think about this. There's a huge disconnect between what we're saying we need to fund the service and provide the data to do it and the money they're releasing. And they have the money. So I'm not exactly sure what's going on, but all I can tell you is we have to get the money that was allocated by the legislators back into the system, like now. All right, let's try the questions again from the attendees to see if we have debunked or debugged our issue. So let's try with Jackie again.
Okay, it says I'm unmuted. Did it work?
Yes, it did. I can hear you, Jackie.
It was a setting on my part. Okay.
Yeah.
You're probably going to answer this, Michael, but I want to know, as a provider in the system, why do we not hear this? Like, this is so obvious to explain the problem and show solutions to all the problems. No one is talking about it. So
Yeah.
that's my question.
Well, yeah, and I'll answer that in a second. Mary, if you could put yours in mute for a second, 1 second. Here's the thing, Jackie. I've been screaming from the hilltops, right? But you're right. In fact, providers have been told by us CMHs, we got to stay in our budget. We got to stay in our budget. This is what's happening. I have, since day one, I declared a residential services emergency, that we're not paying residential providers enough. And I've literally said, if this trend continues, we'll either have massive cuts to budgets, which you can't really do, or people are going to get hurt. The services are not going to be provided. So I'll let Mary ask her question, and I'm going to cover that later. But yes, we need a unified effort, providers, families, legislators, to say, send the money you already have. Mary? Stephen, you're off mute. Mary, take your thing off mute. Okay. No. All right. Stephen?
So who has the authority to make sure that the money that's been approved by the legislator gets paid to you? Do they have any authority? Does the executive department have any authority?
They
Is it tied up?
they can impel and ask the Michigan Department of Health and Human Services to tell them why they're not doing it. And they can do that. They have the authority to do it. At the state, at that department, Elizabeth Hortel runs that department. She has the ability to go back to the legislature and say, we actually think they're going to need this, not that. And we'll talk about that later. But there's a way to change this. And it's only going to be pressure from legislators to make this happen, and the public, because the department has already said they don't think we need it, which I don't understand that, because in about 2 slides, you're going to see we're all in a huge deficit.
I thought the department worked for the executive branch, don't they?
Technically, yes. It's like the three stages of government, right? The governor and then the departments and stuff, right? But the legislators can compel, have them come in, report, all kinds of stuff. We've talked to the governor about this. We haven't seen any relief yet.
Okay.
Okay, Mary, you want to try now?
Yeah. Sorry, I could not get my phone to unmute.
All right.
Okay,
Um,
Mary, go for it.
So I don't want to put any too much promise in what I'm going to say, but I did have a call this morning with the department. And then I turned right around and had another call with the department about specifically funding. And they are meeting with the actuarial
Good.
and they are talking about doing a rate adjustment.
Yeah.
And I am saying this rate adjustment needs to be massive and significant. So in that conversation, as one of our partner members of this region is presently making cuts to providers due to budgetary issues,
Right.
I have said, is this going to be enough to cover the deficit? There's no guarantee, of course, that we're going to get any relief, but I'm confident that we're going to get some relief. I just don't know how much. And so I'm hoping that for the sake of our providers, that we will be able to potentially, if it's massive enough, that we could maybe go back for those that actually are showing a need,
Right.
and not showing a 15 or 18% profit margin, that we would be able to do some type of retro payment to them to address the rates. So at this
Perfect.
time, it is the first I've heard of possibly maybe they're going to push out some more money. So
Yeah.
no guarantees, but that
Well,
was
and for
today.
those that don't know who's talking, this is Mary Dumas. She's the CEO of the Lakeshore Regional Entity, and I have a slide on them in a moment. And Mary has worked tirelessly in back channels to bring this point home. And so, Mary, I'd like to thank you for your efforts. My presentation is here's the problem, and it looks like we're starting to get a little movement, which is good.
A little,
need-
but you're right. It's not enough. And to be honest, it's not fast enough. And the system is not responding to the needs adequately. And so I don't know, Michael, if it's in your presentation, but last year at the end of the fiscal year, normally at the end of December, there is a supplemental that comes out.
Right.
And it helps cover all those overages that have been experienced throughout the year. That did not happen this year because
Right.
of the disaster that was happening in Lansing about nobody would come in. There weren't enough for a caucus. I mean, all of that stuff.
Yeah.
And so at the end of the day, that hurt our system.
Right. And so those that know me, I'm relentless. We're good. We're getting this money. We got to get this money. The other thing so thanks, Mary. We'll please pipe in anytime. The other thing that's going up is unsustainable specialized residential cost. The cost of providing residential services is tripled over the last several years for many variables. There are some places, very few, my residential providers see this slide and they go, what? Who's doing that? Where it can cost up to $2,000 a day. What people should understand, the rates are all over the place throughout the state and all over the region. What I do know is that we have increased demand, I cover that in a moment, in that area, autism and some other areas that are unsustainable with the current funding model the state has. And so we're going to have to look at that. But that is a major source of need that needs to be addressed. And to me, any cut to a residential or even a family that's trying to provide CLS in their home, self-directed care, any cut to the rates of that is unsustainable because they're already not enough to cover the actual costs. And I've been collecting data in my county for a while to be able to demonstrate that and share. So, I mean, there's some other factors on this slide I covered on this infographic. I can send it out to you. Every single system talks about administrative burden, but I'll tell you, we have a huge administrative burden. It's gone up 25% easily recently. And so, we have to complete nearly 70 audits. a lot of our providers and families that provide services know that all the CMHs do their own. And so we're subject to tremendous duplicative audits that take away time and dollars away from the services. The box next to that is talking about the differences in Medicaid. So I told you we get a piece of, we get a small portion of money for every Medicaid enrollee in our county, but not all Medicaid enrollees are created equal in terms of how much money you get. So there's a box there that shows you the different types of Medicaid and on average what a CMH gets per month per person. 377 for DAB, disabled, age, and blind. Healthy Michigan, which is like a health plan. TANF is folks on Medicaid that are generally low income but don't qualify for the DAB. And you can see there's a huge difference between how much we get for the different types of Medicaid. Here's the thing people don't know. The requirements and the services and the entitlements are exactly the same for each of those groups. So anybody that's coming to CMH, we're seeing the most severe forms of this. We're not getting everybody in this DAB category and we're getting $377 a month for the 10,000 people. We're not. We have more TANFs in Ottawa County than DABs. It's in the weeds, but listen to me on this. The requirements for service, the entitlement is identical. So the time they get into CMH, it really doesn't matter what type of Medicaid they have the same needs. And so we're working with the state to understand this. Don't fund us differently by the different types of Medicaid programs. From the time they get to us, it's exactly the same benefit. I can't go, oh, Sue Stone, she's a TANF person. We can only offer you this, that, and whatever. And, oh, Michael Brashears is a DAB Medicaid enrollee. He gets the full benefit. Everybody gets the full benefit regardless of the funding. So I want to be clear on that. So, of course, the Board Association, that's our trade union for the CMHs, we want to adjust the Medicaid rates, as Mary was saying, to offset the disenrollment of the Medicaid program and the deficits. We want to urge the state, and I have more than this in a moment, to give us the money that was actually appropriated, and then adjust Medicaid rates to actually reflect the cost of services. Right now, it's my belief the amount of money we get for the state does not accurately address the cost of most of the service. The cost has gone up tremendously. We have direct care workers that 5 years ago were making $9 an hour. You can't get anybody to work for less than 20. I know we're doing it, but it's almost impossible. The rates haven't kept up with that. Not even close. So if they reduce kind of administrative burden and give us the money back, we should be able to balance our budgets for this year and look at the future. So I will send this infographic, make it available to anybody that wants it. I'll make sure it goes out in an attachment to all the emails that we send stuff out so people have this, so that you have this information. Now, the discussion I'm having now has nothing to do with the state's plan to restructure the system that people are hearing about. They want to decrease the number of the regional entities or change who manages the Medicaid. That has nothing to do with this presentation. This is simply, we need the money that was promised to ensure that the most vulnerable are protected. And we can provide services with the provider network that's adequately funded. So this is what this is focusing on, not the other issue with the state wanting to restructure the whole system. I'll hold one of these discussions on that once we know their actual plans. So did the slide switch? You should be able to see this big 26 million in the middle of the screen. Did that work correctly, Amanda?
Yes, yep, it's working great.
So what's the local impact of the money that's being withheld? Well, you heard it right from Mary, the director of the regional entity. I consulted with her this morning, and these are real numbers. For the fiscal year that we're in now, if they don't cost settle or release the money, we will have a $26 million Medicaid deficit, which will deplete what's called the Internal Service Fund. That's a rainy day fund in the region. The rainy day fund, we're allowed to put a certain amount of Medicaid in it every year, up to a certain percentage. It's too low, but a certain percentage, to deal with unexpected increases in people getting services that more than we thought. Here's the thing. We'll be out of money in this region to deal with being out of budget in any way by the end of this fiscal year. It's gone, the complete safety net. That means if more people show up to any of the CMHs that we had budgeted or cost increases at all, there's no money to cover it. We go into a deficit and we have to start balancing the budget differently. We have to look at cutting provider rates, cutting certain things. And I'm telling you, it's my belief, and this is just Dr. Brashears in Ottawa, I'm not speaking for the whole region, that we actually can't really cut much. The provider network and our families doing this are already at their breaking points. And so I think that this is a huge thing to understand, that in our local region, if no new money comes, it's not new money. If they don't give us the money that was promised by the legislators, we'll have a $26 million deficit in the region. In Ottawa, you'll see in my slide, will be projected between 5 and 10 million next year, if there's no safety net and the rate of growth continues, which I'm going to talk about. So any questions on this particular slide about our local region? That it's $26 million. And Mary, I don't think I understated it. It's that much if we don't get an adjustment in what we're getting. And it depletes our complete rainy day fund.
Michael, we do have some questions or comments in the Q&A section.
Okay,
Would
well,
you
I'm
like
not going to be able to read those. Does anybody have a verbal thing? I can't pull up the Q&A part on my screen.
Okay, I can pull it up though too if you'd like and read them to
Go
you,
ahead.
whatever you prefer.
Hold on,
Do you
let
want
me
to
just see.
have Mary talk first and then we could do
Yeah,
the
go
Q&A?
ahead. Yeah.
Michael, you had a question for me. Can you rephrase it so I can hear you?
Mary, I was saying that I don't think I'm understating this slide, that it is
No.
indeed $26 million, and it does indeed take away all of our savings
The only
that we
thing we have,
use.
right. So the only thing that I would add to that, Michael, for those of you for just full transparency, when the region went through their financial struggles in 18 and 19, I don't think those financial struggles went away. I just want to be clear. The pandemic hit, so we were flush with money. So people thought the problems were gone. The problems weren't gone. The pandemic hit it. So, then we move into 24 and we have financial difficulties again. So we cost settled with the CMHs that past deficit. The PHP was not required to do that, but we felt it was the right thing to do when we had a surplus of cash. The state is now saying we owe them $13 million. And so we can't bank on us having that $13 million. And so if the state truly does take that money from us, or what they do is they hold it from a payment, we will be broke. We will be in the same condition we were in the past. So if they, for some reason, back off, which I will be honest with you, I haven't filed a lawsuit, but we have the complaint ready. We're waiting for the state to attempt to take another payment because they did take $4 million from me, but they put it in escrow, so it didn't go back to the state's general fund account, which I thought was a win. And then since that, they've stopped taking the payments. The Attorney General is involved. She is trying to work with her client, who is Michigan Department of Health and Human Services, to get them to understand that we followed their template, we followed their instructions, and now they want to change the angle on, they want the money, even though it doesn't meet their template or their instructions or the past way of doing this as far as how to fill out the final FSR to determine if we need to lapse money. So I'm feeling comfortable that we're going to be able to win that, but that could get tied up in court for 1 to 2 years. So we have to be under the premise that we're not going to, the money is not available to us right now. Like we can't just spend that money because is what will happen is the state will take it out of our next big payment that comes to us, and then I will not be able to pay you as a CMH the money for the services that you've already provided.
Right. And so thank you, Mary. I was able to pull up the questions and answer. I'm going to deal with them a little bit later because they're very specific questions. So once I get through my slide deck, I'll go back to that because Rosalie, those are very good questions. Please, people understand that the community mental health of Ottawa County, we're not allowed to have like our own Medicaid savings account. It can only be held at the region, and they do it for us. Right? So what we're talking about is if Mary runs out of money, the region, the CMHs don't have like an extra pot of gold or Medicaid money to throw at Medicaid expenditures. So we literally will have a deficit that'll be very difficult for us to address. It can only be addressed through the reduction of how much we pay for Medicaid services, which I'm telling you, we really can't do at this point. So, but Rosalie, you had good questions on the 19.5 way. I think that was more, they are eligible.
Michael,
Yeah.
Michael, can I add, or do you want me to wait to the
Yeah.
end?
No, go ahead.
I would like to talk a little bit about, so the process that the actuarial company that the state has hired, their name is Milliman, if you've ever heard of them. We don't think the practice of how they're determining rates is sound. So we at Lakeshore Regional Entity hired Wakely a while back to figure out why are our rates so low versus the others in the state of Michigan. We're either like we get the highest rate increase or we get the biggest cut. So it's hard to manage within, the highs and the lows. Like, can we just stay in the middle kind of thing? So we hired Wakely, and through that process, then I was able to talk to other PIHPs, and we were able to, as a group, through a collaborative body that we had formed back when the coordinating agencies went away. We have an organization we pay into. We hired Wakely to do an analysis of the work Milliman is doing to try to help us determine like why are the rates not efficient enough. So in that process, we are getting the report back. We had a kind of a draft review of it yesterday, and it is very telling, and we've known is what the state does is they set one rate for the entire state of Michigan for a CLS code. The problem is that we know for any of us that live in West Michigan that it costs more money to live in West Michigan. It's beautiful here, property is more money, and it costs more money for everything. Homes are more money. So for us to have a rate across the state, it doesn't always work out. Yeah, if you take, like Michael used the example of inpatient, $1,200 we pay for a day, they pay $800 on the other side of the state. So they say $1,000 will pay you a day. Well, that sounds great overall, but when one PIHP has extra money, they can't give it to the PIHP that's short money.
Right.
So is what we learned yesterday with Wakely was that the state is treating us like a Medicaid health plan where we're competitive, like our regions would be competitive against each other, and we're not. We're defined regions. We serve the individuals. Ottawa serves the individuals who live in Ottawa County. You don't compete to take people from Detroit Wayne. So the methodology is not sound. The only other state that does it regionally, like we do, as far as have the state broke up, is Colorado. But the difference is Colorado has an actuarial firm that sets the rate by region rather than at a state level. So that is some of the work that we're doing behind the scenes to try to advocate for better rates across the state. And that they probably have to put more work in and make it at a regional level, which, yes, that's going to take more time. But the reality is, I think it's ethical and it's moral, and it's what we should be doing for the beneficiaries of each region and not just what's best for the state or easiest for Milliman. So that's all I wanted to add.
Yeah, and that's a lot there. It's like you need a PhD in actuarial soundness to figure this out. And we had some questions in the chat that I tried to deal with, but I'll say this. I'm trying to make this as simplistic as possible. And the bottom line is, and you'll see near the last slide, it will say, legislators keep your promise, instruct MDHHS to release the funds so that we protect the most vulnerable. And you'll see a call to action and kind of what we can do about that. But all of the mechanics of how we got there, Mary is correct. I'm looking at the impact, like I said a second ago, regionally, they don't push out more money and they take back that 13 million. It's going to be $26 million. So right now, some of you are in the region. Ottawa reported a deficit last year, and we had enough money in that internal service fund to help us address it, right? So that we didn't have to do massive cuts to things, because we ended the year close to $4 million overspent on Medicaid, and I'm going to show you why in a moment. Kent County has had huge issues with not having enough revenue to address the cost of care in their CMH. And starting next year, if this isn't fixed, there'll be no money for any of the CMHs to deal with unanticipated increase in costs. And, I know in Ottawa, I'm looking at this a little bit differently than some CMHs, but I don't believe I can actually cut a particular rate at the moment. I think they're already at the level where they're not even meeting the need. And so I'm pushing heavy and getting this revenue and us needing it so that we don't have dramatic reductions in what we pay people, even ourselves, to do the service. It's going to start to collapse. And I don't think I'm just being like saying fire in a movie theater. I think we're here. So what is the impact if we don't have this money pushed into Ottawa County? Well, if they don't release the money, they are withholding. Let's be careful. Let's be clear. They're withholding, almost like just. I could think of a more dramatic term than withholding. For the public system, CMHOC, that's us, will have a deficit anywhere between 5 and 10 million if our trends this year and next year. Why? Because the rate of people needing certain services are increasing. They're not flat. If your budget's flat or less than what you have and you have an increase, it's basic math, it costs more, right? And again, we don't get additional funding when the number of people seeking services increase, right? It's only when the number of overall Medicaid people on a certain type of Medicaid increases that we'll get more. But that hasn't happened for several years now because of getting it back down to the original Medicaid criteria. But we've had an increase for residential services. And when I say residential services, I also mean it's not just specialized residential providers or families that are doing that. There are people that have self-directed type of services through self-determination that trying to keep their loved ones in their natural supports, and the amount of community living supports services to do that is increased, and the cost is increased. And we're still not yet there where we need to pay people so that people can stay in their natural settings and not go into a residential setting. But if you go into a residential setting, the residential providers, in my opinion, are not getting enough to maintain health and safety and the care that's needed. So there's an increased need for residential services of all types. There's increased need for autism. I think Katie's on her phone listening to this. She runs the family services for Ottawa CMH and responsible for autism. Every month we look at how many people get into our system. Autism, it's like if you get past the screening, it's 100%. We've had a 300% increase in the amount of people seeking autism services to our CMH with not enough revenue to cover that. And they've been doing a good job to deal with that. But there's a huge increase in utilization. There's a huge increase for crisis services in our region and across the state. The amount of money we're getting doesn't cover those costs. And when we show the state this, they still are using an actuarial sound process that Mary was defining based on data that's aged and not based on the actual cost of care. And that's why they just need to release the funds and then say, what's a better way to look at what we need? Because if the state was on the line, and they might be on, they're going to say, of course, Brashears is saying they need more money. They could be saying stuff like, just balance your budgets, or have the regions just make sure they stay in their budgets. My goodness, if it was just a matter of balancing the budget, That's fine. We just stop providing services. Wait a minute. We can't. Wait a minute. We can't deny service. Wait a minute. I really have no way of balancing a budget when the utilization has gone up 200 to 300% in certain areas. So the state's supposed to keep their promise and fund it appropriately. And, self-directed services through self-determination. We need to make sure the funding is there and appropriate for that self-directed level of care. I'm often talked about, actually, I believe somebody said to me in a meeting, like, Michael, we're not really sure if you're supportive of self-directed or self-determination. I want to be crystal clear, and you'll see a position statement come out at my next board meeting, that I am 100% supportive of self-directed care. My biggest thing is the state hasn't put their money where the philosophy is. They want us to have these programs, but how do you fund it? We have many people that kind of find their own CLS workers. They can't find them. Can't pay them enough. So this is a dire situation. It's not just, the CMH money needs more money. It's not that. There's a huge need. Never have we heard before. I think people would agree. Every time you turn on the radio, mental health issues for kids in school and adolescents, out of control. The prevalence rate of mental illness in our communities have grown. Do you know that our budgets are not even based on standard published prevalence rates of mental illness? Meaning, if the general public is going to have 18% of them have a major depressive disorder, you would think that we would figure that in for the Medicaid recipients. They have a modifier, but it doesn't go far enough. So our budget isn't even based on prevalence rates of how prevalent the disorder is in any community. And some things are not disorders, they're different. They're habilitative, and they're just different abilities that we have to support. So please don't take the word disordered, meaning everybody we serve has a disorder. I was just talking about published mental health prevalence rates of mental health disorders when I was making that statement. So there's an increased need for mental health services for adults and children. It's skyrocketing. No one's increased the budget for that. It's as if the system wants us to fail. I'm just going to say it. It's as if the state is saying, we want a different model. And look, it doesn't work. Look at all the over budgets. Look at all the stuff. Yeah, I'm saying it. The problem is there are real lives at stake here. There are real people that we've made promises to, and we have to keep the promise to them and provide the service. We can't just go, oh, well, I won't do that. I'll tell you that. But I'm telling you, this is really where we're at. All right, I'm going to go through a couple more slides and I'll open up to any discussion. I'll get off the screen. We'll talk about it. So who do we have to contact? There are two legislators really I want us to focus on in our area to send a message of release the funds, have MDHHS release the funds. The first one is Greg Van Workum. He's a Republican representative. He chairs the House Medicaid and Behavioral Health Subcommittee in Lansing. He's from our area. He covers part of Ottawa County, Muskegon, and some other stuff. So he's one of our guys. And he just and I testified in front of his committee several weeks ago. Some of you saw that. And I basically said, you guys did your job at the legislature. Van Workum, you did your job. You set the budget. Now put pressure on the department to release the budget that you put in there. So the legislators are not our enemies here. Be clear. They did their job. Now we need them to hear from folks to compel the department to release the money that they appropriated. So we're going to send this out to everybody, but there's the contact information. If you want to send an email and you want to have some wording on it, I can give it to you. I just don't want the same email with the same language and the same thing. They'll go, Bashir sent it to you. And they'll stop reading the second one because it's in the same format. So that's why I don't like it. Here's the sample. Basically, you want to email these folks with a very simple message, which I talk about in a moment. So the first one is Greg Van Workum. He has Lansing office. Here's the mailing address. There's the phone numbers. Dear Representative Van Workum, have the Michigan Department of Health and Human Services push out the CMH budgets that they need. That's the message, right? The other one is Curtis, excuse me, and he's the chair of the House Health Policy Committee. And he is one also in our area, covers a lot of Muskegon. He goes all the way up to like Manistee, Benzine, a lot of huge region. And he's a very important figure in terms of health policy and having that budget established. And it's the same message. So we'll send this presentation out. You'll have the contact information as well. And the message is, and I'll give more detail in a moment, legislators, keep your promise. What's their promise? The amount of money they appropriated. Instruct MDHHS to release the CMH funds needed to protect the most vulnerable. So there's 3 parts in this call to action. Legislators, keep the promise that you did in the appropriation. Instruct MDHHS to release the CMH funds. Why? Because we have to protect the most vulnerable, which is the public mental health system. So regardless of how you feel about our system, this has nothing to do with how is it structured, what improvements do we need. That's not what this message is about. This message is for this year, release the funds so there are not massive deficits. How much? The PHPs have reported, that's the regional entities that manage the Medicaid for us, to the state, that we already know we have at least $100 million deficit. At least $100 million. And that's not even with all of these regions weighing in yet. Detroit hasn't weighed in and some of the other big ones. So in the system, the state of Michigan, the Michigan Department of Health and Human Services already knows, they already know that the system is short $100 million from its expenditures, from the expenditures we have. We need them, and Mary says there's some movement starting, to start committing to that so that we don't start cutting things. Because there isn't enough money in the rainy day fund to cover all of the deficits. And the state's just not going to swoop in at the end and say, well, we'll cover the whole thing. They're going to hold local communities responsible for a portion of all these deficits. It just doesn't go away. We have to balance it. So the message to these legislators and to everybody is keep your promise, keep what was appropriated. Have the department push out the money. And I can send out a formal paragraph and things to anybody that wants. I'll kind of send it to the group here in a different way. I just couldn't include it in my slide deck. I want you to be able to have individual ways of contacting folks, but we need to contact these legislators, okay? And we need to tell them that put pressure on the department to release the funds. They may have to talk to Director Hartel. They may have to get the governor's office involved. I don't know. All I know is the legislators did their job. Can you believe it? They did their job. No new money is needed for this year. For this year, no new money is needed. Release the funds that were allocated. And I'm saying it like that because I have had to develop that little repetition in my head, or I get lost in the weeds of all this other stuff. CMHs are in deficit. Contracts and services and rates of what we pay for stuff are slated to be cut. CMHs won't have the ability to recoup the money that they've already spent, as Mary was saying, because the regions won't have any Medicaid left in their rainy day fund, known as the Internal Service Fund. And I can't tell you, I have no idea why it's this complicated. Here's what was appropriated. Here's what we're saying we need. Send us the money. If you don't like the way we're doing it, restructure the system. But that's separate from this discussion. Okay, I'll entertain questions or talk about this more. So I'm going to send out stuff for folks on besides these slide decks. You can see who to contact, but we really need people to reach out to it. And again, this is not how the system is structured. It's how it's funded for this fiscal year. Because I know some of you that are on this call are like, maybe we need a different system. That's a different discussion. For this year, send the money to the CMHs that were promised by the legislature. Push it out. Any questions or things you want to talk about related to that?
So far, nobody's hands are raised, but we do have some questions in the Q&A.
Let me pull that up. There it is, Q&A. All right. Yeah. I will send the PowerPoint out to everybody and the slide deck and a recording of this meeting. Okay, I think that's all that's in there. And Rosalie, I'm going to send you can you talk to me about what you specifically mean by the ESTA and self-D employers? Like what, for the group knows?
Hear me?
Yeah.
The Earned Sick Time Act, that applies
Yeah.
to self-directed providers also, which means for every 30 hours, they earn 1 hour of sick time. And right now, it's basically an unfunded mandate.
It is.
And if you have over 10 employees, you're going to have to pay, I think, 72 hours a year. And we don't know where this extra funding, some counties are already saying there is no funding and you have to cut wages, which, how are you going to keep a CLS employee if you cut their wage to pay sick time? So it's concerning.
Yeah, and absolutely right. It's an unfunded mandate.
Hey, Michael,
Yes.
I made a note of that, to talk to Kristen Jordan about that, Kristen Morningstar, about, if they're going to make rate adjustments, then they need to include a rate adjustment regarding that. Let's see if we can get them to bite on that, because I completely hear what she's saying.
Yeah.
Essentially, we're going to give you time, but we're going to cut your rate. So only if you use the time off, which doesn't help people, especially we're not talking about professional people. We're talking about people that live typically paycheck to paycheck, unfortunately. So
Right.
taking any dollar an hour away to give them a paid day off is not helpful to them, because they need the hours. They need the money per hour. So I made a note of that. I will be running that up the chain as well with my request of adjustments.
And it is a medically necessary service if you have to pay, if you're fortunate to have a backup worker to fill in for the one who's off on sick time.
Right.
Yeah.
I mean, I think this is an issue not just with self-D. This is an issue across the system
board.
that
And
at our level, it's not, because we shifted off PTO and went to some PTO, but for those people that don't offer that, it is absolutely an expense that was not built into the rate. So, and maybe that's already on their radar. I don't know, but I will follow up with an email to them.
Yeah.
I just wanted to take a minute, Michael, to thank you for doing this series, because we work in a very complex system. As you know, we oftentimes have to have tough conversations with each other and say, am I understanding this right? Or wait, what about this? And so I appreciate you trying to keep it as simplistic as we can to get the message across, but yet giving it some meat, so people understand that we are skimming the iceberg with this information, but just skimming the iceberg for you guys to have this basic level of information is very valuable and super important. So I just want to say thank you.
I appreciate that. I do want to say one thing, because it dawned on me that if you're an Ottawa County CMH employee or family or provider, is Dr. Bashir saying the end is near? Internally for our CMH, we are working on ways to solve our budget deficit for this year and for any projected next year. So I'm not saying unless we get this money, like I better have this money for this fiscal year or else this fiscal year. We are working diligently within Ottawa County CMH to keep within our budgetary constraints now. And some basic changes we're doing, you'll see next month that we're gonna be okay. And so I can scare the heck out of people. And I have to remind folks that I'm telling you worst case scenarios for the whole system, but our region as a whole definitely has some issues that we have to resolve. And we have to make sure that the region has enough money to fill in that rainy day fund so that when we have changes in Ottawa, in Kent, or in Allegan that go up in cost, we can cover it. And as long as we have an adequate rainy day fund, we can deal with this as a region. So I was remiss to saying this, and I can scare the heck out of people, that if you're a CMH employee or a recipient of care or a family or a board member, we will manage what we have to manage here to make sure that we have a strong provider network, staff, and people getting services. So I can somehow do that. And it was another person said, sometimes I can point out like the negative parts of things. There's really a lot of positive things about what we're trying to do in this region and in this CMH. And I just want to make sure that there's the protection for us to keep doing it. And when the state withholds money from the system, the whole system, it impacts us eventually. But to my folks, we're working diligently, we're working hard to make sure we keep things stable. And so I was remiss for saying that, and I was like, oh goodness, I noticed that like some of my staff were on the line. I'm going, they're going to think we're closing. No. We have a $71 million budget with all of our funding streams. If we have a $5 million overrun, if there's a proper safety net at the region, we can deal with it. That's what I'm talking about. The regions are not funded appropriately to ensure that the whole region is protected. And so I just want to be clear on that because I have the habit of scaring people half to death. But this is a serious issue and we need to take action on because we're already seeing some negative things happen. Like we already know that some residential providers, I mean, I got a letter saying, listen, if we can't adjust the rates to meet the basic cost of care, we don't know what we're going to do. And so I'm working on that and it's not just that group on there. So yes, we have a problem statewide. Yes, regionally, we need the money to be released to us regionally. Why? So that Mary at the region can apply the money as a safety net to plug the deficits we have in our region. And then us come up with a constructive way of addressing them for the future. So I want to be clear at that clarification so that people are not going, oh, it looks like I need to apply for another job or move to a different county. But the system is underfunded and they have the money and we need it. So hopefully that helps as well. So I believe, Amanda, we have a way like I can post in here a copy of this presentation and anybody that entered here through whatever mechanism will be able to have access to that. I believe that's how it works. So I can put some materials in the chat and people should be able to access them. I believe that's how it's done. I would attach my presentation now, but it's still going. And then we're going to send out a video as well.
Sorry, I think you can attach things to in the chat. I also think we can look at all the attendees after this and send out an email with information if the chat doesn't work.
Yeah, I think we'll do both.
Okay.
Yeah. Does anybody have any other things related to this they'd like to discuss? Was this helpful? If this was helpful to you, let me know too. Because it's hard to kind of talk about all the different layers of impact and what this means. Jackie?
So I'll go back to my question, like, why is it that no one is talking about this? Like, I have mentioned this, the legislators appropriating a certain amount of money and then it not all being released. And it's like, you get blank stares. People in CMHs, advocacy organizations. So maybe the why is we don't know, but it just seems, it's just incredible to me that.
Where's the outrage, right?
Right.
Yeah, so like,
and why don't they know? And then let's be outraged.
well, my thing is, I had a couple slides ago. So why is the Michigan Department of Health and Human Services withholding some of the money that was appropriated? They simply don't think we need it. And to me, that just defies logic. We're telling you, here's the stuff. Do you think we're making it up? Are we partners or not?
Okay, yeah.
Well, Michael, that's the real question. Are we really partners? But Jackie, I can appreciate your question. And I think the reality is that we have gotten to a point in our culture that it is not okay for people to disagree, which I completely disagree with that philosophy. And so I think these are really tough conversations to have, but Michael and I have them almost daily. I hate to say it, but and there's times we don't agree. Like I just say, well, I can't get on board with what you're saying, Michael, or I don't see it right now. But it doesn't mean I disrespect him or his opinion. It's the fact that sometimes we see things from two different levels. So, I mean, Michael and I talked about this exact thing yesterday about really what I would love to see regionally is I would love to see, as we're going through these financial challenges, for us to partner with our providers to work together to advocate for more money, for a better funding of the system, and not pit providers and CMHs against each other. We are all on the same team. We want the best care for the individuals that our providers are serving, our residential providers, and we want you to be paid adequately. And so it doesn't have to be us and them, it's us. We're all in this together, and that we need to use also, and when appropriate, advocacy groups to say that we're all in this together. There's zero reason why we shouldn't be on the same page about this. Does it mean we might have to go through some changes? Yeah, we all might have to make some changes. But at the end of the day, we want to serve the people that we are responsible for in Region 3, the most fiscally responsible, but with the highest level of care that we can get so that they have the best life they can have in this region.
And I'll tell you, one of the variables, and I see other hands up, I'll get to them in a second. One of the variables, Jackie and others, is us CMHs don't all agree. And that's a problem. Philosophically, you got some CMHs that don't care if the regional entity disappears. You got some that, and by the way, we are the regional entity. The CMHs are the members of it. We form it. And Jackie, I know that because you were on the board. The reality is, within our own region, we don't even agree on certain things. Now, with Mary and I and others, we're all trying to work together. But that's one of the issues we're having, is trying to come together and join with providers, join with it. And each CMHs have to be on the same page on some basic minimum ways to advocate. And I know I'm working tirelessly on that part. And I know there are differences in how each CMHs appropriate things. Since I've been here for a year, I've done 9 community meetings. Why? Because people need to know stuff, and I work for them. I've met with providers. And so we have to do better to do that. And I think, Jackie, what's also happening is this issue of restructuring the whole system. The budget shortfalls, this is just Dr. Brashears' belief, is being used as evidence on why we need to change the system. Well, that might be the case, but until you do that, no harm should come to people. No harm. So fund it, then rearrange it if you think it's not being run right, or if there could be changes in benefits. We could always improve. But what I can't believe is that there's no outrage of, we're out of $200 million. Now, our board association does it, but we haven't really asked families to do much, Jackie. We've been trying to do it.
So I have 2 responses. Yeah. One is, some of it, when we think about the state, MDHHS or whatever, it feels like confirmation bias. Like,
yes,
they believe that we're overfunded, that we're rolling in the money, that we're squandering it, whatever. And so then they're doing things like not giving us money to confirm that bias. But my question is, you just mentioned, CMHAM. Like, I looked back in their publications, I don't see them talking about this underfunding issue, and yet they represent all of you. So that's like, I mean, to be really frank, that's my question. Like, where is CMHAM on this? Why is this not being shouted from the rooftops by those organizations?
And I would say they have been. It just hasn't made it out to the field. Like, I send out as much as I can, but I'm telling you, the board association, Bob Sheehan, Alan, they put together that information. They've been saying this stuff for over a year. The thing is, it hasn't been yet, and they've been trying to do it through, remember, we had to renegotiate contracts all at the same time. The CMHs with the state, the regions with the state, and these were all being addressed at the same time. So a perfect storm happened a couple of months ago. And now we're like, I guess you're not going to release the money? So, Jackie, I think you're going to see a huge step up on that. But it also starts in every CMH, making sure their folks know what's going on. And we're not uniformly doing that across the system. We're not.
Mm-hmm. Yeah, I agree with that. And certainly telling providers and us telling our stakeholders and getting it out, I mean, that's a great strategy. Yeah.
I think the other thing, Bob, is that people forget, Michael, that Bob's association functions on a very small budget, and
Right.
it runs off PAC money. So as a PIHP, we're not allowed to make donations of the Medicaid dollar, because the only money I get, you guys, is Medicaid money.
That's right.
I am not allowed to give money to the board association to advocate on my behalf. I have to do that out of my private account. My personal, Mary Dumas donates this money. And so there's 10 PIHPs. So how much do 10 PIHP CEOs donate? Probably not a lot. But it goes back to that conversation of they try to do mass mailings. They do those action alerts. So if you're not on them, I would encourage you to get on them. You go right to the website. Michael's staff, I'm sure, can find the link and send it out. Yep. And you sign up. And then when there's an action alert, it sends it right to your email. You click on it, you add your email and your name. And after you do it once, the next time it's already in there. And then it just fires it off to the legislators or whoever we're advocating to at that time. But we're not a health plan that literally donates several $1 million to a lobbyist to lobby for us. That's the truth. We don't have that kind of money. We function on literally a pittance.
True. Dawn, then Rosalie. In Boston would say Dawn Parker.
Hi, can you hear me?
I can.
Sorry, it took me a second to get off mute. So as a admin folk that represent an ABA provider, speaking, I think it was to Jacqueline's question, why isn't anybody talking about it? I mean, we've been screaming from the rooftops about our rates. The minimum rate was just approved. Obviously, contracting, we're still getting that all completed. The DCW is still a component of that we're still trying to address. So when we reach out to MDHS, they're saying, yes, it's included. You need to go back to CMHs. So it's like they're pitting us against one another. So we're screaming it. We're talking about it, but maybe we're not asking the right questions, because we're being told by the CMHs, you guys are at a deficit. And then we're told by the state that they have the funding, they need to pay it. So it's just this really weird situation where maybe we just need to be asking different questions. So I think the information that you're sharing is beneficial. And of course, I will give that to our leadership and additional team members and association that we also work with in Michigan.
No, I appreciate that, because, it's very easy to say, it's like a good, I'm half Italian, okay? It's like a good tomato sauce. The state says, it's in there. Okay, and it's all in there. The DCW increase, the ABW increase, all of these things are in there, in the rate. Trying to pull them apart and figure out how they calculated it and things like that, dramatically different story. And I'm like, there's not enough sauce. I don't care if it's in there. There's not enough sauce. And I'm a very simplistic man when I think of it this. Yeah, it may be in there, but it doesn't matter. There's not enough of it. So when I was testifying in front of the Medicaid and Behavioral Health Subcommittee on this issue, I said, all this energy on who is going to manage the system, health plans, PIHPs, LMNOPs, and I'm like, it doesn't matter. Who in their right mind wants to manage the system that's underfunded? Why are people falling all over each other? Well, I'll tell you, our current system is not. And there's enough money to make the... What's that?
Michael, I would say also the other thing we have to remember with the autism rate that we want to keep in mind is that was legislatively determined, not actuarially sound. We have no evidence that that's an actuarially sound rate. It's $66. That's the rate that was approved by CMS. I actually spoke to MDHHS this morning about straightening out, is the DCW in there? Is it not? I mean,
Right.
it is a disaster, and we get what we think is clarifying information, and then we get another email that debunks the whole thing. So it's very difficult to track this.
Yeah,
So
it
that's
doesn't
what
align with their own cost survey reports either. So
no, and for me, from a PHP perspective, you're telling me my rates are actuarially sound, and then we throw a dart and say $66 an hour. Well, where'd you come up with that? I don't have any evidence that tells me that that's actuarially sound. I don't. And I'm not saying it. I'm not saying it's too much. I'm not saying it's too little. I'm saying it's not actuarially sound.
Right. And how do we know that? Because we're reporting deficits. So what do we have? We're not adding like 20% admin to every code. Okay. So something's structurally wrong. And it's really bizarre that the disconnect of a money appropriated to money given based on a methodology that doesn't cover the actual cost of care. Believe me, CMHs are not making 25% admin and all this stuff. Our admin rate as a system is less than 10%. Believe it or not, our system has less overall admin as overall percentage than most other systems. So it's not there. Now, Rosalie had her hand up for a long time, and if I don't
real
get
quick,
to
Dr. Brashear, on follow up to what you said, with them potentially looking at a reason to change the model, but to your point, no matter what kind of model, it needs to be budgeted correctly. And if they're going out for an RFP, the MCOs are not going to necessarily want to work with the state that's withholding money, that has a history of withholding money. So
no,
that's a
but Don, I think the everybody thinks you solve an issue with more efficiency. That's one variable. You come down to what does it actually cost to deliver the care? And that's the piece that is difficult for whatever reason to people to be honest about. I ask my providers, how much does it cost? Right? We're not even paying the rates to cover their basic costs.
we would agree with that.
And so it's like, well, that can't be right. Well, it is right. We're not even covering the basic cost of care for people to deliver the service that we've contracted for them to actually provide. Can I get an amen? So if we get the funding back, we can address it, change the system. But don't hurt the people. Don't hurt the people. Change your system. Don't hurt the people. Fiscal year 25, keep your promise. Send the money out. Get it into the field. Then you can determine all this other stuff. Do it when people are made whole. You want to change the system? Make sure all the budgets are at zero. Don't have deficits. You're going to give a new system. Hi, I'm the new PHP. We just restructured the system. You just inherited a $100 million deficit. Who's signing up for that? You'd be an idiot to sign up for that. Rosalie, what do you want to say? Because I'll keep talking. You know me.
Oh, I want to appreciate the virtual participation option finally,
Yes.
and that I actually went in person to be told it's only virtual,
Yeah.
but I appreciate that I'm on. But
Yeah, we'll
thank
get
you so
better
much
at our
for that.
communication. We got it out late.
Exactly. It all boils down to communication. And the websites for CHAM is not user friendly. The
Right.
website, even though LRE revamped their website last couple years, it's not easy to access the meeting minutes or the invitations to the board meetings. The public is participating more, but people are unaware of the public mental health system. And
No,
even the actual families and consumers, we don't know what we don't know
that's right.
because it's all scattered and fragmented across different websites, Facebooks, and even the Lakeshore link didn't have what the Facebook has. So people get frustrated, and why even try to keep up with what's happening or what can I do or not do, because it's so miscommunicated unintentionally. But I appreciate the progress that is being made and all your hard work, and you too, Mary Martlet Dumais, that it's endless for
Right.
all of us, but we do have to collaborate and communicate. But how can we do that more simply?
Right. Now, I appreciate that and well taken. And I'm getting dangerous now because I'm starting to figure out this Zoom web platform. So look out, everybody. I'll be dangerous. I see some of my board members are online and some of our employees and some families I'm aware of. I appreciate that. Amanda, you had your hand up a second ago. Did you want to say something?
I didn't have my hand up. If
It
I
had
did
it
it,
as your hand was up, yeah. Not anymore. You've disappeared. So, all right. So what are my next steps? I'm going to get materials out. I'm also going to work with Mary at the region if we need a different targeted message in a very specific way. But I will send out, if you're going to contact a legislator, here are the basic themes you want to say. I'll give you that. And you can do that. You can also independently call anybody you want at the state about this, the Michigan Department of Health and Human Services. There are contact information that we can put out there. You can talk to them directly. I know our board association, everybody has been, but it sounds like from Mary's comments today, there's at least the dialogue starting to open up on this. There are many things that we need to improve on in the system. So let's not defund it just because you want to rearrange it. Don't defund the system because you want to rearrange it. Don't defund the system so you can rearrange it. Cuts and changes to the system should not come on the back of the most vulnerable people that we serve. That's everybody that CMH serves. We serve the most vulnerable of any population group. We do that. Families do it every day. Staff do it every day. Don't defund the system so that you can change the system. And I know I'm making an accusation there, but the basic logic doesn't play in. If we say, here's the deficit and you have money, why can't peanut butter and chocolate come together and be a Reese's Pieces? I have no idea. It's something different here. So I'm glad there's some movement happening, but we're to keep the pressure on. And I'll be scheduling other discussions related to this as new information comes in. So look for that. Next Friday, I won't have one of these sessions because I'll be in Syracuse watching my daughter graduate. But the week after I will. I'll have another Did You Know series and we'll get them better advertised quickly. And a recording of this will be made available. Any final comments from anybody before we end? All right. I appreciate it, everybody. Talk to you soon.